Cheryl Lee, let's start with you. You opened your private dental practice 1985, treating patients with severe physical challenges. What did that experience teach you and guide the policy-making aspect of what you do?
Well, that's an excellent question. I saw the need, and I was trained at Howard University College of Dentistry and the pediatric residency, and my heart went out, and I decided that I would focus on patients with severe mental and physical challenges. That was a population that seemed to have been forgotten about. And so my practice grew from seeing 6 patients to over 3,000. But what I saw initially was that all of these patients are wards of the District of Columbia, and they're on Medicaid. And the fees for Medicaid hadn't changed in over 20 years. And so the DC government decided at that point that treating patients with disabilities, they would increase the percentage of reimbursement, but it was only in that population. Mm-hmm. But what about the other population? Of course, children were allowed to have dental coverage, Medicaid coverage since the 60s, but after the age of 20, then it stopped. And so it's important that everybody's covered across the board. And now most of our patients mine are senior citizens, and they don't have coverage. Very limited. It's either emergency care or you just see them.
And how does that affect their lives?
Oh, well, of course, there's studies out there that show that adults have lost more than one tooth. And of course, if we connect that with nutrition and being able to eat, and then with a toothache, you don't brush. And so then there's periodontal disease involved. And we all know or have been made aware of at this time how the oral cavity affects overall health.
Fred, we're going to go to you. Families USA has an Oral Health for All campaign. Can you tell us a little bit about that?
You bet. A goal that all Americans believe in, we all are fighting for. Health should be something that is there to ensure we can all live our fullest life, not a reward for a certain job or a certain kind of insurance. And we've been dedicated to oral health care for many, many years. And fundamentally, what we know is, as you've heard today, mm-hmm. There are so many ways that oral health care really impacts the ability of somebody to live a healthy life, the health of their entire body, their mental health, their chronic illnesses. But it also has influences on, here we go. Sure, no problem. It also has influences on their ability to work, their ability to be social. We know that right now in this country, if you're a person of color, you're much more likely to not been able to secure employment because of the condition of your mouth, your gums, your teeth. Right. We know that you're much more likely to feel shame about the way that your mouth looks, the condition of your gums and teeth. And so at Families, we are very dedicated to the idea that in order to achieve health for this nation, we've got to address fundamentally the connection between the mouth and the rest of the body. And I have to say, I started working on these issues decades ago, and in particular in the United States Senate about 15 years ago. Mm-hmm. Before that, I had worked with primary care associations, with public hospitals, and we've come so far. And I think we should be really proud that understanding and awareness of the American public of oral health care has come so far. The percentage of folks that actually have access to health insurance, dental insurance, has gone up significantly. And the conversation with policymakers, as we heard this morning, have really changed. Initially, I worked for a senator from New Mexico, one of the poorest states in the country, a majority minority state, and we would travel the state, and we would go to health policy commissions all over the state. And the number one issue that the doctors who were working on the commissions brought to us was oral health care. That was the number one issue for the people of New Mexico. They said, we've got to address what's happening in their mouths because we can see the impact on the rest of their bodies. And back then, it was so hard to really get policymakers to focus on this issue. Oral health care was sort of seen as a luxury.
Right.
It wasn't seen as integral. And last night at dinner, we were talking about this. It was the death of a young man here right outside of DC that really galvanized, Diamante Driver, that galvanized action in DC, in Maryland, and in the United States Senate. It really changed the whole conversation. When a young man dies because of a cavity that's gone septic and then eventually into a sepsis and eventually into death, that's not a country any of us should be living in.
Marko, you're an economist, and you've written a lot about how expanding coverage will save money in this area. Can you talk a little bit about that?
Yeah, and let me just first react a bit to what Fred said. And you heard the Congresswoman say about the job search prospects,
right,
and the employability of people, what Fred's alluding to. Like this, I think, is changing the conversation, right? We are paying an economic penalty in the status quo. And if you look at the data and that issue that she mentioned about lack of coverage and poor oral health limiting your job search ability, the data are crystal clear. If you are a low-income adult and you live in a state that doesn't have adult Medicaid coverage, you're twice as likely to say that poor oral health limits your job search skills, right? So compared to if you're living in a state that does have adult coverage. So I don't know, to Fred and to Cheryl's point as well, like I think we're at a point where maybe the momentum is building. We have much more feathers in the cap or bows on the arrow, whatever the analogy is, in terms of saying, look, it's the top unmet healthcare need. The top. Not prescription drugs, not primary care, not vision, not eye. Oral health is the top unmet need among low-income adults and seniors as well. We have an economic thing. To your specific question, we did, and we worked with Families USA and Community Catalyst. We crunched a lot of numbers. And if you look at when we did the report, there were 28 states that didn't have adult dental coverage in Medicaid. And we estimated it's about a $1.1 billion investment per year that you would need to cover dental care for adults in Medicaid in those 28 states. Now there's an offset as well of about $300 million in medical care cost savings. That's a really, really conservative one.
Right.
So I think if you're talking about, I loved what was said earlier about an investment, right? You need to think of this as generating savings elsewhere in the healthcare system, in reduced emergency costs, in reduced chronic care, medical care expenses, et cetera. So I think, I don't know, we're having more of the pieces of the puzzle, and I think we can talk about kind of what's needed to go to the next level. But in my view, there's wonky data, there's lots of personal stories. I would be disappointed if it takes a Diamante driver in some state, an adult on Medicaid, a senior that loses their life because of that. I mean, do we need that to drive policy? I mean, I think that's almost shameful. We have what we need.
I'll follow up on that, but I want to open it up to the other panelists. But you mentioned state coverage. You know, in Washington, there's so much gridlock. We talked about the death of Build Back Better, which had some provisions on oral health in there. We're seeing with abortion now policies really being made at the state level more and more. Is that how to change the system? Is to go state by state? Obviously, ideally, you want to have federal legislation that applies to all the states, but with the gridlock in Washington, is that where the battle needs to happen?
I don't know enough about that. I mean, I'm not in the advocacy space, but I will say that I think there are two potential federal solutions.
Okay.
Right? And I think one is to basically say, like we did for children 20 odd years ago, oral care is an essential service in Medicaid for adults. And you basically have a federal policy, right, where you must, and it should be comprehensive and adequately funded, et cetera. I mean, I don't know the gridlock, how big it is and how much of a lift it is to get that stone up the hill. The second policy option to explore is simply enhancing the subsidy from the federal government to states through the FMAP, right? Like we did this through the ACA, right? You're expanding Medicaid rolls, the federal government will pay, almost all of it for a certain number of years, et cetera. This is what I'm talking about. Another option is to say, if you add adult dental, you will have a significantly enhanced match from the federal government, at least in the first X number of years. So I would say those two are the options to explore. Now, politically, what's more feasible, that's not my forte.
Your forte, though. What do you think?
And prior to coming to Families, I was running healthcare for the National Governors Association and working with a lot of state Medicaid programs. And the first thing to say is, absolutely, incredible progress can be made and has been made on the state level. You know, we're now at a point where basically half the states have pretty robust oral health care coverage, and another half are sort of in either none or some.
But what has been? Let me stop you for a second. What has been the key there to getting that progress?
So without a question, it's raising the awareness of policymakers of that connection.
Okay.
The body and the mouth connection. Incredibly important. And I also think the norms in our society are changing around oral health care. People's experience of having access to insurance coverage that covers their needs, their oral health care needs, has helped them to be able to access care. So we're also changing in terms of our national understanding of oral health care is changing. But I was going to say, you know, we have to remember that unlike the federal government, states have to balance their budget, so they can't just print money if they're spending too much money. And I've sat there in the room with governors and Medicaid directors when, for example, Sovaldi hit a very, very expensive drug to treat hepatitis, and the first thing on the chopping block was oral health care, adult dental oral health care, because it's seen as a kind of luxury at times, which it isn't. And if you look back at the recession in 2008, the first thing that was cut was oral health care, and in addition to some optional populations. So I think we have to understand that there's a fiscal dynamic on the states. And just to reinforce Marko's point, we have to show up in a way when we're advocating for this to understand that concern and address it and not ignore it and jump over it. Because if we don't address it, we won't win this. And ultimately, if you think about this sequentially, every single state that is currently covering oral health care in a meaningful way, if we can get a bill through Congress that says, hey, we're going to make this a mandatory benefit, but we're going to show up and help the states pay for this, cover the cost, every single one of the states that's currently doing it becomes a champion for this bill because we're filling in part of their financial spend, right? And eventually, and not everybody agrees on this, but eventually, you know, we've been fighting to make sure that there's actually the adult Medicaid benefit can get all the way to become a Medicare benefit. And if you think about that interaction, what happens is the spend on the Medicaid side becomes an offset for the Medicare side. So we're just building the case slowly but surely to create a unified, comprehensive, ubiquitous, meaningful oral health care benefit. And I would say, if you look at the trajectory of this, we're well past the halfway point on this. We are really making a lot of progress. And I spoke directly to Speaker Pelosi on this. She was 100% on board. The HR 3, the prescription drug negotiation bill, had the Medicare dental benefit. I mean, we are making progress here.
Cheryl Lee?
Yes. So I just wanted to say that having adult Medicaid is important, but it also can't be the Band-Aid, because the state might say, we're offering adult Medicaid, but we're restricted in the treatments that we're allowed to do. So does the coverage only cover extractions and doesn't cover replacements? So I want us to be clear about that. And then you have, I think I was on a webinar, the ADA gave it, and they were talking about different states who will allow dentists to sign up for Medicaid but not treat one patient. Marko, you probably remember
Those were
that
our
one.
data. Yeah.
And those are the states that I think you're referring to. I think Maine was one of them that absolutely does that. So it's important. And then, of course, you know, the National Dental Association supported the dental benefit in Medicare. And so I know we're working really hard to make that a reality. But just give the adults quality insurance so that we can do what we do, and then also not restrict us, because there are a whole lot of things that we can do, even down to, you know, periodontal treatment and having them to have access as readily as they need it. And then the only option of extraction wouldn't be the only thing on the table. So I just want to make that point.
What can the administration do? We've talked a lot about Congress and pending proposals, and there's legislation by Congressman Berrigan and Senator Cardin out there as well. But for any of you, what can the administration do that you think, okay, this will help, that you don't need legislation for?
Fred, do you want to jump in?
Well, sure. I would say, I want to say, you know, we've worked really closely with the the Centers for Medicare and Medicaid Services with HHS on this. We have a whole new role within HHS around oral health care. The Biden administration is 100% bought in. They've got great staff who really understand the importance of this. So I think right now they're working really hard to encourage states to expand adult dental, to work with them, check that box on your state plan amendment, start offering that benefit. I think they've been pushing behind the scenes congressionally to say, look, we can show up in a much more meaningful way. And I do think that ultimately, as we've heard from all the panelists, it's that fiscal interaction with the states that's really at the core of this. And I think that they are real champions in trying to get Congress to step up, not only create a requirement that adult dental is covered, but also to help the states cover the cost.
Fred, can CMS do an enhanced match, or that's a regulatory change, or that's a legislative change?
Generally speaking, it has to occur. It's a statutory change because the FMAP formula is built into the statute.
And what about I really love what Cheryl raised about we're using coverage loosely, right? So far in this discussion, you hit a really, really key point. What are we talking about, right? We just heard the Congresswoman this morning poll the audience about satisfaction with coverage, and we know there's tons of problems with the current dental insurance paradigm, right? But what states have got it right? That you're not just funding extractions, but you're actually funding, Cheryl, jump in, I'm not a dentist, right? Endodontic treatment, right? You're funding perio treatment to retain teeth. You're doing the stuff that's clinically necessary versus like checklists of procedure. And shout out to CareQuest for leading the charge, and we were happy to contribute in terms of measuring this coverage in a really, really good way. Like what states do provide endodontics, prosthodontics, dentures, et cetera.
Right.
How would we design a benefit like we did for children, EPSDT, that says you got to provide this. This is the minimum basket. Is that, again, regulatory or is that legislative? Like you got to cover these services.
So it's both, but that is an important policy consideration in building the legislation, right? There could be a link between the quality of the coverage and the ability of states to pull down that federal match. We can actually create a connection there to say, if you're going to show up and provide a comprehensive benefit, you get full match. But if it's something less than that,
you don't get
a
full
dollar,
match.
right? So there's a lot of ways to incentivize states to get it right. And then, of course, CMS ultimately, in a regulatory sense, will define the quality of coverage that we'll get, that will qualify. Right now, because it's optional, it's pretty much an open season on a $500 benefit, $1,000 benefit, whatever states feel like doing. I will say, in terms of a good example, one of the things I'm really proud of is District of Columbia is definitely a really good example of a jurisdiction that is putting a lot of resources behind oral health care, and it's an example to the rest of the country.
Yeah.
And a shout out to Natalia Chalmers. I mean, we have the best chief dental officer in CMS. So, Fred, now's the time.
So can I just say one thing? And I saw the statistic too about the District of Columbia, and I was really pleased about that. But the one thing, being the boots on the ground practitioner, even with how great the statistic looks, what makes everything difficult in my shoes is that a patient comes in, you diagnose them, you create a treatment plan. But in order to provide, and this is straight Medicaid, in order to provide optimum service or health care for these patients, you have to prove that you're telling the truth. There is so much red tape. You have to do everything except for offer your firstborn to be able to provide optimum health care to patients, and it shouldn't be that way. And I understand there's risks and there's concerns and lack of trust. But if your record shows that you are providing these kinds of treatments and making people better, it may take weeks in order for you to be able to be approved to provide treatment. And I think that needs to change. Now, I don't know too much about the political arena and all that legislative process, but that's why we have you. So help us, Sister Howard, please.
You better believe it. That's what we're here for. And the paperwork burdens around providers being able to become eligible for Medicaid it's not just a dental problem. It's a problem throughout the program. And so we're with you. And it's a really important piece. The other dimension of this as well, I think, is we know that most dentists don't accept Medicaid. So even if we have the benefit in place, is there real access? And there's a lot of dimensions to that. The thing that people point to right away are reimbursement levels,
That's right.
which of course really matter. But the other dimension too is it's about how diverse is our workforce? Are we training dentists who are part of the community that we want to serve? Or do they see that community as other? And this is a problem throughout healthcare. I'm the son of Latin refugees, immigrants. I'm gay, and in my life, having representation in the healthcare workforce has really changed my life. And I think within dentistry, we see that it's a very, very homogeneous workforce. And that's part of the concern too, is how do we bring much more diversity into the dental workforce?
Marko, the effect of COVID to the industry and oral health in general, both short-term and long-term, what are your concerns? Because as we heard the Congresswoman said, she hasn't gone to the dentist. There are a lot of people, it's not a cost issue for her, but there was a lot of dentists who had to shut down, and then people are not getting the care, and then that's going to lead to short and long-term effects.
Yeah. So, I mean, hers is a minority case in terms of not going back yet, right? But our latest data show roughly about 90% of pre-COVID patient volume. That's where we are today.
Okay.
Right.
Has that gone up dramatically this year?
It's gone up this year. The last few months, it's in a holding pattern.
Okay.
So we're calling it kind of potentially a steady state.
Right.
What the biggest concerns are with recovery right now are staffing shortages. Yeah. So we have crystal clear data that it is a major, major problem. We have 40% of dental practices hiring, and over 90% say it's impossible to hire, very difficult or impossible to hire staff. So that's part of what's keeping the capacity down. That's partly why we're at 90%. In terms of the patient side, there aren't any indicators of some type of long-term, I'm not going to go back to the dentist, or I'm going to go once every 2 years. I mean, we've done an incredible job as a sector, I think, to reopen up safely. Cheryl's the boots on the ground, so to speak, as part of this, but to really instill confidence in the public. So long term, I don't see any big kind of implications. Short term, we do have major issues hiring hygienists and dental assistants, and that right now is problem number one.
What have you seen on the ground?
Well, the pandemic affected our private practices immensely, and to be shut down, and I remember it like it was yesterday. It was March the 18th, and we weren't allowed to reopen until June 8th. So it was 10 weeks because we were categorized as non-essential healthcare workers, which was absolutely insane. And we could only treat emergencies, but everything went on lockdown. And then with the population that I treat, even after we were allowed to reopen, they were still on lockdown for months. And so
folks may not be aware of the population that you're
I thought I had said it earlier, but it's patients with severe mental and physical challenges. And so they are all in group home settings, and they were just on lockdown. And then, there was the question about how dental offices sterilize and disinfect their offices. And we've been at the top of the game since the AIDS pandemic back in the 80s. We took particular care, but then even with this, we even went as far as having the air recirculated and disinfected. If somebody sneezed, the air would be changed and cleansed, and they said 10 seconds. Is it true? Well, I don't know, but I believed them, and we put that in our practices. So it's just been really tough. And have we gotten back to where we were pre-pandemic? No, we just have not. But the types of problems that we see have increased just because they haven't been able to gain access.
So they're worse because they haven't seen you for a while.
That's right.
Right. Now that makes sense. Frederick, as far as a model, whether it's internationally or statewide, as we all know, it all comes down to money and costs. And I've talked to, when I covered healthcare, so many people were frustrated at the Congressional Budget Office because they said, well, they're not giving enough credit for preventive money. Is there data out there that you can cull and make the case to entities like CBO?
So, great question. And I spent a lot of time with CBO in my life. And the joke about CBO is everybody hates them because they're never saying what folks want to hear. It doesn't matter what side of the aisle you're on. What I would say is, first of all, the data are very clear that providing preventative oral healthcare services can reduce overall healthcare spend significantly and really lead to a healthier person, a more productive member of society, all those things. That's very, very clear. In my experience, and obviously I would never speak for CBO, not on their staff, they are not particularly convinced by those sorts of arguments. And they think in very kind of green eye shade terms. We know that the Elijah Cummings Act was scored at about $240 billion. That's an earmark for, if we provided every single Medicare recipient oral health care, that's what it would cost. That gives you kind of a high watermark here of the kind of money we're talking about. I think that ultimately there's a lot of interactions. Will it come in? Would a full Medicaid oral health care benefit for adults come in that high? Definitely not. But it's probably over a 10-year score, at least half of that. And that's real money. Right.
Marko, your thoughts as the economist?
No, look, the CBO's full of wonky economists like myself and stuff, so I'm brethren with them, Fred. I get it. It's a very hard buy for research, right? Do we have RCTs and that kind of research on this? No, but I'm with you. My take too is that we've moved, even in the last 3-4 years, we've moved the research and evidence base significantly, right? And that's part of your work, part of our work, part of CareQuest's work. Moving away from the federal, I do want to say that at the state level, the feedback has been very clear that these fiscal analyses have actually gotten the bills over the finish line. It's kind of eased the fiscal hawk, so to
different
speak.
situation.
It's different stakeholder, right? But I don't want to underestimate the value of that kind of wonky work, right? It's like, we've heard from Maryland, you heard from Mary, in Virginia, in May, they literally were like, okay, now we have some numbers. It's not this huge ballooning of the budget we thought it'd be, and it kind of got the bills over the finish line. So I get it. It's a bigger lift for CBO, as Fred is saying. But I think at the state level, I'm certainly proud that
I completely agree
fiscal
with that.
work. Yeah.
Completely agree with that. That kind of research, when it works with the governors, it's exactly what we need on the state level. And remember, the investment at the state level it's of a different magnitude because they get the federal match.
Right.
And it's an add-on to their existing program. So as a percentage of their total budget, it's not that high. And but it's a kind of data that policymakers, governors, state legislatures want to see to understand, is there a way for me to know in a meaningful way this is going to make a difference in the lives of my constituents? It's going to have an economic benefit to the state. That research on the state level is incredibly important. And it's important on the federal level. It's just a different dialogue, and CBO is kind of built to be hyper skeptical.
Right.
So.
Right.
We have run out of time. I do, on behalf of the Hill, I want to thank our sponsor, the CareQuest Institute for Oral Health. We'd like to thank everyone for joining us and those who joined online. If you missed any portion of today's discussion, the full event will be available on thehill.com shortly. Thank you very much. Have a great day, and please thank our great panel.